After radiology, either you can get into one general practice of radiology, but there are different super specialties where you can get into, like fetal medicine is one of them. You can get into MSK specialties. You can get into neuroradiology. You can get into either diagnostic neuroradiology, interventional neuroradiology, and then you can get into intervention radiology, like myself.
If you want to get into IPL team, then this is one of the ways.
IPL, Bangalore Football Club. If you want, celebrities coming after you, I think MSK radiology would be.
They can email you if you're really interested to. Hello all, this is Dr. Dheeraj Masapo. I'm a senior consultant in the field of neuroanesthesiology, and this is a long awaited video. Many of you have requested me since long time, and he is Dr. Dheeraj. He is a specialist in interventional radiology. Okay, this is a video we've been requesting since a long time. So welcome to the channel, Dr. Dheeraj.
Thank you, sir. Pleasure to be here.
So today basically my first question would be why did you choose radiology and why did you venture into interventional radiology? So what is your journey and story behind?
So firstly, even during my undergraduate days, I was always interested in radiology. I felt that radiology had a very important role in decision making and management of the patient. Of course, the lifestyle also was attractive, but more than that, the involvement in the patient management really attracted towards diagnostic. But then there was always something in the back of the mind that you have to pursue IR. I was more of a procedural guy more than open surgical procedures. So when I got into diagnostic, I saw some interventional procedures, and finally I got into intervention radiology once I finished my diagnostics. So the journey has been so good. I haven't looked back since then.
So basically, what is interventional radiology? Because many of the audience are like MBBS students and who are writing NEET exams. So some of them are radiologists also. So what is exactly interventional radiology?
To put it in very simplistic terms, intervention radiology is anything which you see or do with an image guidance. So basically, we don't do any blind procedures. Whatever we do with either an ultrasound or a CT or a cath lab. It's always under some kind of guidance. So simplistically put, intervention radiology is radiology with doing some kind of procedures. And again, it's not a very new branch. It's one of the oldest branches, I would like to put it. In fact, the first intervention radiology procedure was done by Charles' daughter. He's called as the father of intervention radiology. And the first procedure was done in 1948 in US. He did a SFA angioplasty. So it's actually a very old branch. But there is a wrong perception that it is something very new.
What is SFA?
A superficial femoral artery.
Femoral angioplasty.
So peripheral angioplasty, he did it. So in fact, he's the father for most of the branches, even interventional cardiology and endovascular things. Everybody considers Charles' daughter as father of their branches, but he is actually an interventional radiologist.
He's a common father for many. So then it started there. From there, it evolved to a next level now.
It evolved to a next level, and what happened was intervention radiology has been inventing procedures, and a lot of subspecialty branches they started adopting. Especially cardiology, initially a lot of procedures were done by intervention radiologists, but then interventional cardiology became big, and mostly the entire cardiovascular system is adopted by cardiologists now, and we don't really foray into interventional cardiology. So like that, some of the procedures have been adopted, but mainly most of the procedures are still retained and being done by intervention radiologists.
So examples, can you tell us what are the common procedures?
Definitely. Intervention radiology is actually a very wide array of procedures. I would say the subspecialties within it is neurointerventions and body interventions, to put it to classify it broadly. And in body interventions we have GI and hepatobiliary interventions. Then we do peripheral vascular interventions. We do common procedures like varicose veins, peripheral angioplasties, and we do a lot for interventional nephrology and interventional pulmonology. We do a lot of procedures, and in interventional oncology, in fact, we are the fourth pillar of oncology, wherein we are a mainstay of non-surgical procedures involved in oncology.
Oncology, what kind of procedures?
Like now, predominantly, I do a lot of interventional oncology procedures. We are involved starting from the diagnosis. In fact, any patient who comes up with a swelling or a tumor anywhere, the journey starts with a biopsy. So once you do a biopsy, that's when you have a diagnosis. Why we are involved? We do these biopsies, we do these diagnostic things in a very minimal invasive things. Even in very difficult locations and critical areas, we're able to take samples from them without causing any kind of difficulty to the patients. In fact, we have done samples from very close to the heart, pericardial pleura. So there is always a danger element involved, but sometimes you need to do that to stage the disease, and consultants ask specifically for that. So, and also that is one on the diagnostic aspect. On a therapeutic aspect, we are also involved in many therapies, like especially in hepatocellular carcinomas. We do procedures such as transarterial chemoembolization, transarterial radioembolizations. These are therapeutic procedures, and also microwave ablations, which we do for a lot of liver cancers, and also cryoablations and other ablations for renal cancers. So it's actually, we have a wide gamut of procedures, especially for interventional oncology, where we are involved both in diagnostic and therapeutic as well.
Got it. So diagnostic and therapeutic, both components are there.
Definitely, sir. Definitely.
Okay. So it also depends upon the hospital where you're practicing also.
Definitely, sir. Like right now, I work in a big onco setup, so my procedures are mainly interventional oncology, but again it differs from place to place. Like we are very we are commonly involved in hepatobiliary and transplant procedures. In big transplant centers, we work very closely with the liver team, again starting from diagnosis and even managing a lot of post-transplant complications. We are very actively involved with transplant.
Example, like what kind of complications?
Complications such as post-transplant, you have hepatic arterial thrombosis, you need PTPDs, and you have this HepJ strictures. So we are commonly involved. So we have a wide array of procedures for post-transplant things. Even in renal transplant, post-transplant interventions like renal artery stenosis, post-transplant, we are commonly involved.
So basically, so intervention radiology is involved with all the specialties, I think.
Definitely.
Gastro, onco.
Gastro, we are very.
If ERCP fails, I think you have something.
That is when we are called for, type 3, type 4 procedures we have to do, and even tips.
Yeah, tips regularly.
BRTO.
Very common procedure.
Very common procedure. You have for Budd-Chiari syndromes like drips, hepatic vein stentings. So GI is a very
GI is
close
one
branch
area,
to
onco
us.
is one area, and transplant is another area. Neuro interventions are going on.
Nephro-uro interventions. Nephro-uro, so it's huge. Like we are involved in renal biopsies. We are involved in perm cath placements. For renal dialysis access, actually we work very closely with them. In fact, in places where there are huge dialysis centers, we are involved in day-to-day management. We actually help in planning the fistula, which are the better accessible veins. We also are involved in management of any dialysis complications, any fistula complications, any central venous obstructions, fistula thrombosis. We used to do a huge number of procedures in big dialysis centers.
Oh, right. Fistula, if fistula is blocked,
Fistula is blocked.
then,
that's when we get.
I've given anesthesia many times. Dr. Dheeraj. So yeah, I got
We used to do a lot of fistuloplasty.
Yeah, fistuloplasty we used to do, yeah. Because there will be a lot of pain when you're doing the procedure.
When we do this plasty, sometimes patients have a lot of pain.
So most of the times we do only the sedation only. We don't give general anesthesia because most of the patients are very high risk patients.
Sir, the way we actually advertise our procedures are such that daycare procedures and minimal invasive procedures. So we try to most of the time try to do it under local anesthesia or maximum under MAC or sedation. GA is very rarely used by us.
GA is risky also for your patients because most of your patients will have so many complications and all that. So by default, giving GA would be risky actually.
That is our USP. The way we sell it is minimally invasive daycare. You go back home in the same day. So again, another common area we do is this thyroid. So thyroid nodules, everything. We do this RFA. Even today we had procedures of thyroid radiofrequency ablations.
Thyroid and RFA
we do RFA ablations, and these are same day procedures. Patient can go back home in a couple of hours.
Okay.
Very easy way to avoid surgeries for all the benign thyroid conditions.
Even for breast tumors also some procedures.
Breast tumors also we do procedure called as VABS. It's called vacuum assisted breast biopsy. Wherein lumps which are even 5 centimeters can be removed in just a matter of half an hour. And these are also again daycare setting. You come and you go home in 3 to 4 hours. Same day.
Uterine fibroids also something.
Fibroids are different kind. We usually keep the patient for a day in the hospital. Fibroid embolization is one of the most commonly done procedures, and it is done in patients whom we want to preserve the uterus.
Okay.
So uterus has a lot of functions, like apart from childbirth and fertility, it plays an important role in support for the pelvis with all the ligaments. So one of the important misconceptions among people is once you have attained, you completed your family, it is necessary to remove the uterus whenever you have something. That is actually a very wrong notion which we're trying to spread. We can retain uterus, you can have the functionality, but we can alleviate all the symptoms. Like heavy menstrual bleeding is one of the most common symptoms with which people with fibroids turn up to. With uterine fibroid embolization, we have managed to save a lot of women with uterus, and it gives 100% effect that all these symptoms have alleviated within the next cycle itself. It's one of the most effective procedures I have seen.
And one more, what is that, emergency postpartum hemorrhage?
For PPH hemorrhage is one of the life-saving procedures.
It is life-saving.
It is life-saving. Again, it helps to save the uterus.
Yes.
It helps to save the mother.
In many cases,
I think that's it is commonly such that we want to be involved in more PPH cases where we are called upon, so that we can save hysterectomies and we can save this blood loss. It is done both electively and also in emergency setting. If you have patients with, let's say, placenta previa, placenta accreta, where you're expecting a lot of blood loss, you're keeping the interventional radiologists in the loop. It helps them avoid a lot of anxiety.
Okay.
Already obstetricians are under a lot of pressure whenever they have such risky cases. But when you have a tertiary setup with an interventional radiologist, you can always have that peace of mind that we are there to help them out in such emergencies, and you don't need to take drastic steps such as hysterectomies.
And coming to this point, in smaller places, even now they lose patients.
True, sir. In fact, there's RCOG has a guidelines wherein whenever you are doing such case of high morbidity cases, you have to keep the intervention radiologist in the loop. And even if there is no intervention radiologist in your hospital, you have to have some kind of tie-ups with places where you have IRs there, so that patient can be moved quickly in case of excessive bleeding and things like that. RCOG has a guidelines for that.
So freelancing does okay, we'll come to the next question is, so now I think we covered different areas that intervention radiology has a role in the hospital. Next question would be like if somebody wants to get trained after MD radiology, MD radiology is the only way, right? To
MD or DNB radiology.
DNB radiology. So then like what are the different centers in India they should go to?
So initially there were very few centers where people could go and learn IR. The centers which have stood over the time was SGPGI, Lucknow, and KMC, Coimbatore, CMC, Vellore. These have stood, and they were the only centers which were doing good IR work initially. But even when we came out of our MD, there were very few centers. Like DMs were around just 7 to 8 seats.
But DM is there?
DM was there, so it was very difficult to get into a DM. There were a lot of fellowships available at that time. So, but right now the scenario has changed. A lot of DRNBs have started in most of the corporate centers. So it is quite available in most of the places. Getting into is much more easier than how it was earlier.
Okay, super.
But my thing would be that intervention radiology needs a lot of support branches. It's not a standalone branch where you can practice alone. So you need a lot of support structure in terms of infrastructure, in terms of the other super specialties.
What are the equipments you require from A to Z?
A to Z in the sense we need a cath lab for sure. Some centers do work with a fluoroscopy, but ideally you need a cath lab. So a good cath lab, a good CT machine, a good ultrasound machine, and these would be the primary things which you need. But then again, the equipments which we use are also slightly expensive. So that kind of support is needed even from the hospital setting or things like that.
So cath lab, ultrasound, and you need CT.
Just to put it at the basic level, these things we need.
But these three are there in many setups in even tier 2 cities, tier 3 cities.
Yes, sir. In fact,
scope is there.
Definitely, scope is there. Right now, I think most second-tier cities in Karnataka have good interventional radiologists. I think we have been able to penetrate even these areas. So there is a good scope. These are basic things you need. But there are higher things like cone beam CT and things like that which we use in some places that everybody can afford. And most of the places it's not that. There are a few select centers even in Bangalore which can have that. But basic things like I explained, if they are there, you can start off with all intervention radiology procedures.
So then, for example, I am from a town. No, not tier 4 city or town or whatever you call it. So I want to go back to my town. Is it possible or not?
Definitely possible, sir. In fact, like I told, interventional radiology is a wide array of procedures. Even if you don't do cath lab, there are a lot of things you can do just with an ultrasound alone. People who do only varicose veins and they are able to do really well in most of the cities. For that you just need an ultrasound machine. You can do all biopsies, you can do all FNACs, you can do VAB biopsies, everything you can do with just an ultrasound machine alone. It depends upon what kind of procedures you get in your place, but not necessarily everybody does everything. Like even in my setup, I do predominantly onco, GI stuff. I don't do neuro. So like that, it depends upon the area and the hospital which you are working at, the kind of procedures you get or the kind of IR procedures which you actually do.
So even if you want to go to town also, I think according to Dr. Dheeraj, it is possible.
Definitely, you can tie up with everywhere you have to have some kind of collaboration, some tie up.
Please explain that part also.
That is very important. The networking is very important for intervention radiologists. That is one of the difficult part of IR. The sense that we are aware about procedures. Some specialties are aware, but to reach to common people that we are able to do, that is one area where we are really lagging at.
How to do that? Like social media is one way.
Social media is one thing. Even if you Google them also, there's a lot of misinformation regarding these procedures. So ideally, when we are trying from our society, from our things, we have a lot of outreach programs, like especially with fibroid embolization, every year or half a year we do these campaigns like Save the Uterus, wherein we try to involve both the obstetricians and the general public and explain that simple procedures such as fibroid embolization can have such a huge impact.
Got it.
So we are trying to reach out to masses, we are trying to reach out to all the people, but yes, there is a lot of information to put out there in terms of intervention radiology.
I feel the trust will come only when a treating clinician refers.
Correct. There are a few cases where we directly get patients like direct referral for varicose veins and thyroid and things like that. But we are always referred from some kind of physician or a surgeon. So I think primarily we had to reach out to the surgeon. We had to reach out to the obstetrician, the physicians, and explain to them that there is always a chance that we can work together. The important thing what we have to do is you
become a threat actually.
We never become a threat. That is exactly that exactly is a wrong notion.
That fear will be there. If I am a surgeon, if you are coming, I will think that you will do all the procedures and intervention, and you become a threat. So
that is actually a notion which we are trying to change. That is definitely a myth. So there is a wide variety of patients which we can treat. One patient may benefit with the surgery. One patient might actually be an ideal candidate for an interventional procedure, a simple procedure. I think by both the primary physician and us as IR, we are trying to do the best for the patient. And once we reach out to the physician, I think I'm very sure that everyone have been warm and welcoming to new ideas. And once we establish that comfort level and that the connection, we do get along well with most of them.
Actually, my opinion I'll tell here. Actually, the ideal way is if you have a patient, better to send to a minimal invasive procedure first, so that the patient would always think that you are not trying to directly go for surgery. You are actually trying to solve this problem in a minimalistic way.
Correct.
First, let them try to solve the problem. If the problem is not solved, then the next step will be surgery.
Definitely.
Correct, no? In that way, you will actually gain trust of the patient.
I think we should call you for our IR society to explain this concept as well. And it's actually an interesting way to put it. Definitely, so like you told, once everybody gets to know, I think the notion will change.
Because patient, as soon as you see the patient, if you tell surgery, if you prescribe, then they will think that you are aggressive. So if you try to convince him that actually surgery is required, but I am trying to avoid it, I want to send it to an intervention person, and then once let them try to solve it. If we can settle it out, then we can avoid general anesthesia, we can avoid blood loss, we can avoid all dangerous complications which can happen with surgery. So
definitely.
So in that way, actually, I don't think you never become a threat. You'll be a facilitator.
We are not a threat. That is one of the. That is definitely something we want to change. We are not a threat. I think we can work together for the better for the patient. I think there's a scope for every specialty. I think once you, if you look at it at a very super specialty level, there are a lot of gray areas. But I think if you do good work, you earn the trust of the clinician, you earn the trust of the patient, I think definitely you'll get more procedures and you'll definitely get more patients from that.
Got it. So, see, basically how I look at it, intervention radiology is between surgeon and radiologist. That is correct, no?
Correct, sir. That is a good way to put it.
It is because the typical radiologist would want to have a cool life and like multiple coffee breaks and all that. And then we'll focus on this one. Now AI is also coming. They'll be more into tech and this kind. That's how radiology is going. But intervention is not like that. Always there will be blood on the hands.
We love blood.
Blood on the, and the risk is there. Tension is there. Because see, when you open and do some procedure, everything is under your control. When you're actually going with a wire, risk is more.
You need that exact tool to get into, and if you don't have that exact tool, if you don't plan it prior, I think you'll land up in a soup in IR. So with open procedures, you have that comfort level. You have that comfort. You can think about it and do something. But with this, we need the exact tool at the right time.
So a different mindset is required totally for intervention. So then, like for example, abroad opportunities, if any of this thing.
Definitely, sir. There are a lot of options. Especially UK has a lot of options. Okay. One for training in IR. I think
after finishing, for example, after 5 to 10 years experience in India for intervention.
In diagnostic radiology, I think most of them in India, radiologists, they give the FRCR exam. Okay. So once you finish that FRCR exam, you are qualified to work as a consultant in UK. Oh. So if you have some kind of background in IR, like if you have a fellowship or a DM, and if you have some other degrees like EBIR, I think you will be able to find places for consultant in intervention radiology in UK as well. And US is a little difficult. I think US has gone to a different pathway wherein you don't do diagnostic and then do a year of fellowship in IR. US is starting as an independent residency in IR. So it's been started since the last few years, wherein after you finish your UG, you can directly get into IR. It's an integrated program of 5 years. So US has gone into that mode now. So US might be a little difficult for that.
But doing radiology and entering will be better because you understand everything.
Yes, I think there will be some rotations in diagnostic also even in that program, but predominantly IR.
So I run a WhatsApp channel actually. It is just to help people. I don't make any money out of it. So I get forwards from all the agencies on jobs in Middle East, Dubai and all that. So IR is very commonly coming nowadays. That is why many people request it actually.
A lot of intervention radiologists in Middle East are from India who have trained in India and who are working there. So there are good opportunities.
Opportunities now. Middle East. So many of my subscribers are interested to go to this Dubai and Australia and all that. Even there, I think intervention radiology will have a good scope. No?
Definitely, sir. Australia may be a little difficult. Middle East,
there is a scope.
Definitely, probably. But India is a good place to practice IR right now. There is a rapid growth of intervention radiology in the sense that most of the big centers are looking for an IR if they don't have one already. So there is going to be a good growth potential for IRs in India right now, even first tier and second tier cities. It is not that saturated compared to some of the other branches.
Yes, exactly. I agree, totally agree. Because the saturation level will come to know, actually when you're trying to find for a particular person, if you're not getting him, that means that field is not saturated. Correct? So many hospitals are trying to get intervention radiologists and they're not getting. Because I know like they're trying in several hospitals and they're not getting people with good experience. So that means the field is not saturated.
And people who are on the fringe, like they are not sure whether to do complete IR. Like I only practice intervention radiology. Many of my colleagues practice only intervention radiology. But there are a lot of them who do predominantly diagnostic and they do some procedures. So people who are on the fringe that, should I take IR, should I not take IR? There is always that comfort level. You can try it out. You don't need to do the entire procedures. You can start off with just breast biopsies. Whatever is required in your center, in your setup, you can do those limited things as well.
Got it.
So You don't have to do a TIPS procedure. You don't have to do the biggest procedure. You can always start off with something new. FNACS biopsies, I think every radiologist can do.
Got it. So you can actually practice radiology and little bit of intervention.
Especially this apprehension is there in women.
So radiation exposure is more. There is no doubt in that, no? In your field.
I think there is, definitely there is radiation exposure for us, for interventional cardiologists. I think we all share that.
What precautions you take?
We are very concerned about it. Whenever we enter into a cath lab, we are well protected. We wear our lead vests, jackets. We try to keep radiation level as low as possible. So, is it too much of a concern? No, but whether you had to be careful about it, definitely yes. You take all the precautions. Is it something that should deter you from getting into intervention radiology? Absolutely not. Okay. Earlier there was a notion that, especially a lot of my friends in radiology, women especially, they used to ask that does radiation risk impact them in the future? My answer is no. There are very competent female interventional radiologists in Bangalore. A lot of my colleagues are like wonderful intervention radiologists. A lot of my juniors have seen them. They are, if not better, they are as good as any.
Got it.
So I don't think it is a concern at all. Some of the best intervention radiologists in US are also women, and I don't think that concern has to be at the background of anybody. I think we have to be careful, but that should not deter you from taking IR for sure.
Got it. So what are the risks associated? Because general radiology will not have any risk. The risk of wrong interpretation, misdiagnosis may be a risk, but patient-wise no risk will be there. But here, what are the risks and what are the worst things which can happen?
One thing, radiation we already spoken about. The second thing coming to it is risks are involved like any other surgical modality. You do critical biopsies, you do procedures like that. There's always concerns of bleeding, there's always concerns of some complications. But the risks are low if you practice with some strict guidelines, maintain some safety standards. I think you can always be on the right side of the line. And the other risks would be sometimes when we are not able to achieve the kind of result which you are not able, which we want to achieve.
Reaching the location is tough.
Reaching the location sometimes you try a couple of hours, 4
6
hours.
Also I've seen you doing.
So my earlier boss used to have a dictum. He told he had A and B. That is, A is if you're not able to reach what you wanted, like if you keep trying, and if you get tired, then plan B. Plan B is again take some time and try again plan A. So one thing I would like to tell about IRs is we have a lot of patients in cath labs, like have seen most of the specialities, but somehow we are very persevering. We rarely give up a case just because we are not able to get into any artery or a smaller branch. I don't think we have never ever given up on things. We have sat there and done cases for 5 hours, 6 hours, and until we get into the smallest branch, we will be continuing to do so. I think that's one of the good qualities among most of the intervention radiologists I've worked with. We never give up on most of the cases. We always try to keep persevering.
Maybe that is the way to get the result. Maybe
that is how we prove ourselves to clinicians and the system as well. So.
Got it. So then anything else you would like to tell the juniors who are watching this video or aspiring to become interventional radiologists? A word from you.
Main thing I would like to say is that it requires a mindset. IR, especially when you're coming from diagnostic, there is a comfort level which you achieve in diagnostic, the timings and shifts, and when you switch over to IR, you must be ready for the sacrifice. Try to work more longer hours, and I think if you have the passion for the subject, passion for the field, it will be easy. We have been called upon in midnights for embolizations, for bleeders. So once you get the rush of the procedure, rush of the feeling, then you'll be able to do anything. So it shouldn't be that, why I should let go of my comfort level. I'm having a good life in diagnostic.
My subscribers, most of them want work-life balance, and so what is your suggestion?
So I think the work-life balance is kind of skewed in IR. Yes, I do agree that it does take a hit. Sometimes we've been called on
some days you have to come.
All big days, birthdays. We have come for cases and things like that. But that's part of our job, I think. As specialties which manage emergencies, you had to be ready for that. You had to be on calls. It comes part of the job. I think once you get over.
So now my next question would be, so after radiology, where all a radiologist can venture into? What are the super specialties?
After radiology, either you can get into one general practice of radiology, but there are different super specialties where you can get into, like fetal medicine is one of them. You can get into MSK specialties. You can get into neuroradiology. You can get into either diagnostic neuroradiology, interventional neuroradiology, and then you can get into intervention radiology like myself. Suggestion would be, after radiology, even if you're not sure what to take up, you don't have a specific interest, would be to try some time as a general radiologist. You will pick some area where you think you want to venture into. Like some people who want to get more into patient management, like myself. So we tried intervention radiology and that worked out for us. For people who just want to do diagnostic but stick to one area, there are neuroradiology in very good centers, like you can do your DM in NIMANS.
That is like in the brain, all the aneurysms and AVMs, the embolize and coil and flow diverters and all that.
That is one of the really good specialties, interventional neuroradiology, and again MSK is a very, very good field as well.
So what is MSK?
MSK, musculoskeletal radiology. They are involved in a lot of sports imaging has come up. So I know very good MSK radiologists who are involved in IPL.
If you want to get into IPL team, then this is one of the ways.
IPL, Bangalore Football Club. If you want celebrities coming after you, I think MSK radiology would be.
Some of my followers want to become like that. Celebrity doctors. Then
everybody wants to become like that.
Then MSK radiology is one of the best, guys. Note down this MSK radiology. Yeah.
I think MSK was very tempting to get into. We saw a very good MSK radiology. Shrikant sir was there. I think he tempted me into MSK, but stood in IR.
Yeah.
So that is one
modality. Is one, neuro is one, interventional.
Fetal medicine is huge. Fetal medicine and fetal interventions are huge. A lot of my colleagues are in fetal medicine. They're doing really good, and that especially women like to get into fetal interventions and fetal medicine. They're doing really well. That is again one very upcoming specialty. Cardiovascular imaging.
Okay. Oh, that's a separate.
That's a separate thing. They have good fellowships in Satya Sai. There are a lot of fellowships abroad. Even in Jaideva as well, there's a good fellowship. So cardiovascular imaging is another separate branch. And
so many are there actually.
So many are there. Are a lot of earlier. Usually, it is not an end branch anymore. So like even like anesthesia.
Anesthesia is there. Cardiac, neuro, pediatrics, so many are there now.
When we took it as end branches, but definitely it's not an end branch anymore.
So world has changed. I think niche specialists. I think you have to be specialist in one zone and I think go deep into that.
Definitely.
Oh, so much of scope is there in radiology, and thank you very much, and lot of information we got about radiology and more about intervention radiology, and so you will have so many followers in my channel now who want to become intervention radiologists. Guys, you can comment in the comment section and we will answer them, and we will do a Q&A session in future.
Definitely. Finally, one thing I would like to say is there are a lot of people who apprehensive to get into diagnostic or radiology thinking that there is saturation. There is saturation in every field. I don't think there's anything which is not saturated, especially in big cities like Bangalore. But if you have a passion for it, if you have interest in it, there is always good centers where there are pockets of good openings available. I see really good doctors in every super specialties of radiology. It shouldn't be in the back of your mind. It shouldn't hinder you from getting into radiology for sure.
Good.
If you have an interest for it, please take up radiology, please take up intervention radiology. You will always find good jobs anywhere you go.
But see, previously, and actually in any counseling, I don't know why toppers take only radiology. What is the reason behind that?
I think initially it was all the lifestyle and the money involved, but
First 100 ranks if you take, it will be general medicine, radiology, pediatrics, general surgery, radiology. It will go like that.
the money and the lifestyle made the choices. But I think people are getting wiser now. They think that other branches are making more money than radiology. So I think medicine and
I think more than money, lifestyle is one.
lifestyle,
No night duties.
diagnostic, the lifestyle is still good.
Good, no?
It is really good.
Lot of coffee breaks.
A lot of coffee breaks, 9 to 5 job. Some day you have duties, but most of the days it is a planned day for sure. You don't have to carry any baggage from home, from office to work, on the back of your mind. IR is different.
IR is different. So guys, IR is totally different. That is what, if you want to become his follower, then your life will become tougher. So superb. Then a lot of information we came to know. Thank you, Dheeraj. Thank you very much for coming into the channel and giving all valuable insights. And this video is going to impact many people, and many people would take radiology after looking at this interview. That is how the social media will have impact.
It was my pleasure to be here, so it was my pleasure to have this chat with you. I hope that a lot of people are, take this information and make good choices and get into intervention radiology, and be very happy if a lot of people got into it.
Yes. In future, many of my subscribers might come to you for training. They might become your trainees.
I'll be happy to.
No, can they come for the observership if they want it?
Definitely.
They can come.
Easily they can come.
Guys, you can come and do like a few days or a week of observership.
Anytime you're welcome. You're welcome if you want to spend a day to see how an intervention radiology department works and what we do in a day. I think that is something lacking in medical colleges.
Correct.
I had no idea what an intervention radiologist would do in my MBBS days. Nobody had that idea. But now you have that option. Most of the places are very friendly and very open to have postgraduates coming in to have a look for a day or a week to see how things work before they make their choices.
Yes.
That option is definitely available.
Correct. No, before making a choice, better to stay.
They had to, sir. They had to see.
Yeah. So at least maybe a week, I think you can spend with him, and then take an informed decision, like informed consent. You have to take an informed decision.
You can. Once you see that, then you'll be able to make up your mind whether this is what you want to do.
Yeah. So in the description, I'll keep the hospital details. So if you really want, you can contact your email ID. I'll give to them, so they can email you if you're really interested to do the observership. Okay. So thank you very much. As usual, Dr. Dheeraj Masapu logging off. Roger that.
So I am also Dheeraj.
So both Dheeraj logging off. Roger that.
So who's the original Dheeraj?
For my channel, I am original.
I'm starting a channel of my own.